This is a case of a 66-year-old male who presents for routine dental checkup and cleaning. He's asymptomatic. His sleep history is normal. His past medical history is positive for factor V clotting disorder, blood clots in his leg, chronic back pain, neuropathic pain disorder in leg, hypertension, and high cholesterol. No known drug allergies. He's currently taking Coumadin, venlafaxine, hydrochlorothiazide, gabapentin, baclofen, lovastatin, zolpidem, and losartan. He had a spinal fusion done in 2010 and plastic surgery in the 1980s. His family history is positive for heart disease, diabetes, and cancer. For the social history, he's retired and he's a Vietnam veteran. For the objective exam, during the extraoral exam, all of his findings were within normal limits. He had normal blood pressure and pulse, normal findings of all the palpations of craniofacial muscles and temporomandibular joint, normal exam of glands, normal mandibular mobility with a normal opening, no joint noises were found. The intraoral exam also showed normal gingival, alveolar, and mucosal tissues, good posterior contact. He had a class 2 overbite, and salivary glands were within normal limits. When doing the intraoral exam, tooth number 19 was found to have decay on the distal under the crown margin. There was slight percussion pain, but nothing significant. The probings were within normal limits, and no pain on palpation. And this tooth number 19 was non-vital. The radiographs taken were bite wing and PA. The periapical radiograph of tooth number 19 shows endodontically treated tooth with a post buildup in crown, and there was a periapical radiolucency at the apice of the roots, as you can see in this periapical image. The bite wing radiograph shows an open margin on the crown, on the distal, with recurrent decay, as seen here below. So for the assessment, apical periodontitis was diagnosed. Tooth has a poor prognosis with recurrent decay and prior root canal post buildup in crown. So for the plan, I recommended extraction of tooth number 19 to discuss option of implant, bridge, or partial. And number 3, I wanted to consult with the patient's physician about the extraction due to the patient having factor V clotting disorder and taking Coumadin. I'd like to request a current INR value. So what is factor V clotting disorder? Well, this is an inherited disorder of blood clotting caused by a mutation of factor V gene. And this increases the risk of developing factor V laden thrombophilia, which would be actually abnormal blood clotting leading to possible blood clots. The factor V protein is involved in a series of chemical reactions that hold the clot together. The molecule called activated protein C prevents the clot from actually getting too large by inactivating factor V. Now, people who have this factor V clotting disorder, the activated protein C is unable to inactivate the factor V normally. So as a result, the clotting process continues longer than usual. And this will increase the chance of developing blood clots, abnormal blood clots. So people with this factor V clotting disorder who have had deep venous thrombosis or a pulmonary embolism are usually treated with blood thinners or anticoagulants. So as I mentioned, the treatment for this condition would be a blood thinner such as Coumadin or warfarin. So with Lexicomp, Coumadin is described as an anticoagulant or vitamin K antagonist. One of the effects of dental treatment could be mouth ulcers or taste disturbances. Also, signs of warfarin overdose may first appear as bleeding from the gingival tissue. So what are the effects on bleeding? So there was a study that assessed the amount of bleeding during a single tooth extraction in patients who remained on warfarin during the procedure versus those who discontinued warfarin. And all patients had coronary artery disease, but there were no significant difference in bleeding with or without the warfarin. So 40 patients underwent tooth extraction. They were divided into 4 groups: the continuation of warfarin without interruption, warfarin bridged with low molecular weight heparin, and warfarin bridged with unfractionated heparin, and a control group of healthy individuals. There was no severe postoperative bleeding in any of the patients, and the number of used extra gauze swabs did not differ significantly among the groups. With the aid of local hemostatic agents, dental extractions in patients receiving warfarin who have had an international normalized ratio or INR from 1 to 4 could be carried out without a significant risk of bleeding, without altering the anticoagulant regimen. There was another study with 109 patients that completed the trial. 52 were in the control group, which was warfarin stopped 2 days before extraction, and 57 patients were in the intervention group, where warfarin was continued during the extraction. The incidence of bleeding complications in the intervention group was higher, that was when the warfarin was continued, than the control group, but the difference was not significant. Continuing warfarin when the INR, the international ratio, is less than 4.1 may lead to an increase in minor post-extraction bleeding after dental extractions, but they found no evidence of an increase in clinically important bleeding. So they concluded there are risks associated with stopping warfarin, hence, getting blood clots, the risk of blood clots, especially in patients who have been susceptible in the past. Therefore, the practice of just routinely discontinuing their warfarin before dental extractions should be reconsidered.